Splitting is really about the heart sounds that you have. A split typically is a finding upon auscultation or listening. Normal splitting is when you have inspiration. Okay? So if you a drop in your intrathoracic pressure. Okay. Yeah. Then you have an increase in your venous return. And so this is your inspiration, your expiration. S1 would be your heart sounds, atrial, pulmonary, or aortic and pulmonary. You do get some sort of a delay. That's normal. When you have a return in your veins, then you'll have an increase in your heart, your right ventricular filling, an increase in your right stroke volume, and an increase in your ejection time. You'll have a delayed closure of your pulmonic valve. Okay, that's what this is. There is a typical delay there as it closes. Then you'll have a decrease in your pulmonary impedance, which is an increased capacity of your pulmonary circulation through the lung as your blood gets oxygen. It also occurs during inspiration, which contributes to delayed closure of your pulmonic valve. You can also have wide splitting. This is seen in conditions that delay your right ventricular emptying, like pulmonic stenosis, narrowing, your right bundle branch block. All causes delayed pulmonic sounds, especially on inspiration. An exaggeration of normal splitting. And so you'll notice here a normal delay. It's all relative to that. And you have fixed splitting. Here you heard in the atrium septic defect from left to right shunt. Again, you're getting this left to right, blood recirc. And you have an increase in your right atrium and your right ventricular volumes. Okay? Because why? The left is moving to the right. So then you have an increase in flow through your pulmonic valve such that regardless of your breath, the pulmonic closure is greatly delayed because of this large amount of filling and shunting. Okay? Then you have a paradoxical splitting. This is heard in conditions that delay aortic valve closures, such as aortic stenosis, left bundle branch block. Okay? Notice these are left or aortic. Okay? And wide splitting deals with pulmonic, and right. And then paradoxical, again, left. Normal order of valve closure is reversed so that your pulmonary sound 2 occurs before delayed atrium sound 2. Therefore, on inspiration, your pulmonary 2 sound closes later and moves closer to atrium second sound, thereby paradoxically eliminating the split. Okay? So here you got a reversal, A2 to A1, P2, and here this is reversed. So a split S2, sound 2, is a finding upon auscultation of the S2 heart sound, typically caused when the closure of the aortic valve A2 and the closure of pulmonary valve P2 are not synchronized during inspiration. Okay? So typically you want A2 and then P2, unless it's paradoxical, just know that it's reversed. Notice S1 is always going to be first sound, that doesn't get mixed. Because the mitral and tricuspid valves, so the bicuspid and the tricuspid, remember the tricuspid is the right, mitral, bicuspid is the left. They normally close almost simultaneously. Only a single heart sound is usually heard. However, in about 40 to 70% of normal individuals, as well as in certain cardiac conditions, a split S1 sound can be appreciated as well in your auscultation. Okay? Next one. Here's a good diagram. Here's your aortic area, systolic murmur. Aortic stenosis, narrowing. You have a flow murmur, physiological murmur from the valve itself. You have your left sternal border. Diastolic murmur, again, typically left side, diastole, and then aortic regurgitation, such as aortic blood circulating back, or pulmonic blood circulating back. And then systolic murmur will be a hypertrophic cardiomyopathy. So you're going to have an enlargement of the heart of some sort, thickening for systolic. And pulmonic area, this is where your systolic ejection murmur occurs. Pulmonic stenosis, atrial septic defect, or flow murmur. And this is where you're actually going to be listening. So you'll put the stethoscope here. So this would be right upper quadrant, first, right below the second and third rib, right in the middle there. And then on the left side, the pulmonary, second and third. The tricuspid area, notice it's the 5. So 1, 2, 3, 4, and 5, right next to the mediasternum or the sternum. And holosystolic murmur, tricuspid regurgitation, ventricular septic defect, or a diastolic murmur, we're using a tricuspid stenosis narrowing. Okay. And then here you'll have the 6th vertebrae between the 5th and 6th. This will be the mitral area apex. This is the apex here on this corner. This is the holosystolic murmur. This deals with the mitral regurgitation. The systolic murmur is the mitral valve prolapse, and the diastolic murmur is the mitral stenosis. Okay. Bedside maneuvers. On inspiration, you have an increase in venous control, return to the right atrium, and in that case, you have an increased intensity of your right heart sounds. Hand grip. Check the hand grip. You have an increase in afterload. You have an increase in intensity. Murmurs. Valsalva, phase 2. Standing up, you have a reduction in your preload, less gravity. Decrease in your intensity of most murmurs. Increase intensity of your hypertrophic or enlargements. Murmurs. Rapid squatting. Increase in venous control return, increase in preload, increase in afterload. Okay. This is actually a popular test question, I understand, on rapid squatting. Squatting, standing up, squatting, coming down. You have a decrease in intensity of hypertrophic cardiomyopathy, increase in intensity of different flows. And then you have systolic heart sounds. These include the murmurs, aortic, pulmonic stenosis, mitral, tricuspid regurgitation. Diastolic heart sounds include murmurs, aortic, pulmonic regurgitation as well. These are what should be happening in your bedside maneuvers if you were to perform them on an exam. Heart murmurs. Let's go in those. Aortic stenosis. You have a crescendo, decrescendo, systolic ejection murmur. A soft sound tube, where you have an ejection click may be present. Left ventricle, aortic pressure during systole. Loudest at the heart base, it radiates to the carotids, however you want to say it. Pulsus parvis L tardus. Pulses are weak with a delayed peak. They can lead to syncope, angina, and dyspnea on exertion, SAD. Most commonly due to age-related calcification in older patients or in younger patients with early onset of calcification of bicuspid aortic valves. Notice it's a little higher here and lower here. Mitral tricuspid regurgitation, holosystolic, high-pitched, a blowing murmur. These are the words that I typically use on the exam. Mitral, loudest at the apex and radiates toward the axilla. Tricuspid, loudest at the tricuspid area. And then the rheumatic fever, This should be important to you. This rheumatic fever is a very popular question. This is where you have an infection of the endocarditis and also cause MR or TR. Okay. Yeah, and just remember, MR is mitral regurgitation and TR is tricuspid regurgitation. That's why we're abbreviating those. Late systolic crescendo murmur. Okay. So remember, crescendo here kind of goes up with a mid-systolic click. Okay. And sudden tensing of chordae teneni. Most frequent valvular lesion, best heard over the apex of the heart. Can be caused by myxomatous degeneration, primary and secondary to connective tissue disease, such as Marfan and Ehlers-Danlos syndrome, rheumatic fever, and chordae rupture. And then ventricular septic defect, that's holosystolic, harsh sounding murmur, loudest typically at the tricuspid area. So here you'll see typically a question arising from one of these. We'll describe it, understand the type of heart murmur you might have, and then you'll have to understand the type of heart murmur. Aortic stenosis, mitral regurgitation. So mitral, again, these are blowing murmurs. Crescendo, decrescendo, that's your aortic. Mitral valve, just a crescendo. And then the ventricle septic, not very popular, but harsh sounding. Okay. And that'll be the end of this slide, this video.